And now we're going to have our presentation on gastrointestinal issues. And we have Dr. John Clarke from Stanford. So Dr. Clarke, are you ready?
Yes, I am. I am going to talk about amyloid and the gut. And I'll say as a background, the background of this slide looks very pretty, but we're in the midst of a heat wave now, and it's about 100 degrees. So I am inside within an AC room. And what I'm going to do in the next 25 minutes is to talk about the patterns of GI involvement, symptoms which are associated, different diagnostic tests that we have, different treatment options, and then I'll talk a little bit about variants. And if you think of the gut, the gut is everything that goes from the mouth towards the anus. And so it includes the esophagus, the stomach, the small bowel, large bowel. And there's different layers within the gut. And so amyloid can typically deposit anywhere in the gastrointestinal tract, as well as the nerves which are around it. Typically, the gut has an inner lining, which is referred to as mucosa, which is responsible for a lot of the local secretion and the absorption. There's also 2 layers of muscles, which are deeper than that, which help move things down. Then there's a layer of nerves which are involved. The gut actually has 500 million nerves which are associated with it. So it's about as many neurons within the gut as in the spinal cord. And as we heard in the last talk, any involvement of those nerves with amyloid can then affect the coordination of the gut. And then finally, we can see deposition within the blood vessels themselves. And the type of symptoms are going to vary based on where the amyloid is primarily felt. And so if it's mostly present within the mucosa, or if there's a significant amount of mucosal involvement, then the main thing that we tend to see is a change with absorption. And what that means is that there's diarrhea, there's malabsorption, there's bloating, there's weight loss. And this is a diagnosis that we can make with endoscopy. Typically when we're going in and doing endoscopy and taking biopsies, the only layer that we can really biopsy is from the mucosa. And so if there is deposition that's deeper to that in the gut, we may not pick it up with the endoscopy itself, but this area in particular, we get very readily. If there is involvement that's deeper than that, that's inside the gut muscle itself, the main problems that we'll see with that are problems with muscle contraction and problems with the motility of the gut. And that can lead to food not getting pushed down as well, food sitting in the stomach, stasis. There's this entity known as small intestinal bacterial overgrowth. And the background with that is that the average person has about 3 pounds of bacteria which are present within their gut. And that bacteria gets cleared out at various points during the day. And if there's less muscle function and things aren't getting pushed down as well, you can get higher amounts of bacteria. And that higher amount of bacteria can then cause problems with absorption and gas production and diarrhea. If there's muscle involvement within the colon, we often see constipation. And there is this condition that we can see that's referred to as pseudo-obstruction, where someone's presenting almost as if they have a bowel obstruction, but the problem is that the muscles are not pushing things through. If there's involvement within the upper gut, then we often will see a sense of nausea and pain. And typically, this area of involvement is one that we're not going to get a good look at with biopsies because the biopsies don't affect the muscles. But we can make that determination with imaging studies if we see gut thickening, with what's referred to as transit studies, where we can look and measure the motility in the gut, and then also manometries, which are where there's a tube that has pressure sensors, and we actually can measure the contraction strength that's there. If there's involvement within the nerves, that was talked about largely in the last talk, so I'll just duplicate a little bit here. The main issue that we see is not necessarily muscle strength, and it's not necessarily absorption, but it's more coordination with the motility. And so what we tend to see is dysmotility, where things can go slow or fast, and you can often get symptoms that are non-specific with that. But the big ones we often see are nausea, pain, vomiting, constipation, diarrhea, getting full quickly. And then we often can see increased sensation in that context as well. This is also an area where, because the nerves are generally deeper than we get to with biopsies during endoscopy, we can't necessarily make the diagnosis with endoscopy with biopsies, but we can help confirm a diagnosis with tests looking at the pressure patterns coordination with the manometry, and then also movement with transit. Then finally, if there's vascular involvement, the main role of the blood vessels are to take away nutrients from the gut and then bring oxygen. And so what we see is that if there is amyloid involvement with the blood vessels itself, we tend to see ischemia plus bleeding. And that's usually a diagnosis that we can make with endoscopy because the bleeding is present there. Now, there's also non-luminal GI patterns, meaning that when we talk about the gut, we talk about the mouth through anus, but there's aspects of the gut that feed into those areas that are not within a direct line. And so liver involvement, bile duct involvement, pancreas involvement, these are all felt to be less common than the other areas that I've talked about. Now, symptoms are often not specific with amyloid, but are more linked to the main area of involvement as well as the layer involvement. And so if we think about the esophagus, which is the tube that connects the mouth towards stomach, if there's problems with the esophagus, we really tend to see two main issues. One is reflux, where things are going down and then coming back up. Then the other one is referred to as dysphagia, which is where there's problems swallowing and getting food down. In the stomach, the main role of the stomach is to help store food, start to grind it down, and then to empty it slowly towards small bowel once it's small enough to actually be absorbed. And if there's problems with the stomach with amyloid in that area, what we tend to see is nausea, abdominal pain, as well as gut distension, and a sense of getting full quickly. With the small intestine, we tend to see more diarrhea, malabsorption, weight loss. And then with the colon, we can see both diarrhea and constipation. So oftentimes the symptoms are linked with where exactly the amyloid is most prominent. Now, there's some caveats that have to be mentioned. One is that when we look at GI symptoms with amyloid, it's important to recall that most of these symptoms are pretty nonspecific and also pretty common. And so if someone comes in with reflux, it's hard to say that's amyloid up front because 20% of American adults will have symptoms of reflux at least once a week. And if someone has amyloid and they also have reflux, it's sometimes hard to know, is that from the amyloid or are they just in the 20% that would have that? If we step back and look at some of the other symptoms which are common, dysphagia is seen in 4% of adults. What's referred to as functional dyspepsia, meaning abdominal pain or else distension after food, is seen in up to 30% of adults. Typically with irritable bowel, it's about 13% of adults. Constipation is about 15% of adults, and more so commonly seen after the age of 65%. Then fecal incontinence is 6% of adults. And so oftentimes if people have these symptoms and they're seeing any specialist, that specialist may not be thinking of amyloid up front. But it's important to know that these symptoms can be seen in higher amounts, perhaps with certain types of amyloid. Second caveat is that just because someone has amyloid, it doesn't mean they can't have something else as well. And so there is still the same rate with inflammatory bowel, with celiac disease, with cancers. And so it's important, if there are symptoms which are new with amyloid, not to just say that everything is from the amyloid, but still to look up and do investigation with that, because sometimes we do find other things. And then third, with a lot of the medications which are used, some of the most common adverse effects which tend to be seen are often GI in nature. And so if you look at most of the meds which are in use, nausea is one of the most commonly seen adverse effects across the board. And they've done studies that show that if someone takes more than 5 meds at any time, that 80% of them will have at least one adverse effect associated with a med or also combination of medications. Now, we do have a number of diagnostic tests that we can employ to better look at what's going on look and see if we can find deposition of amyloid, and then try and tailor the therapy based on that. Typically, endoscopy and colonoscopy are often the first tests which are performed. And during this, we give sedation to make you tired. We then take a long rubber flexible tube and then take a look down. During an upper endoscopy, we can typically look into the upper small bowel, which is about 7 feet down. During colonoscopy, we can look typically into the lower small bowel, and we usually go up about 9 feet. But there's still about 20 feet in the middle that we can't necessarily get to without advanced equipment. But what this allows us to do is to take biopsies and see if there's any deposition within the mucosa. And then if there is any bleeding, then we can treat that at the same time. If there's any strictures or narrowing, then we can stretch that also. Most of the time, the findings are relatively non-specific, and it's important to know that this will pick up only the mucosal deposition. So if we're concerned about nerve involvement affecting the gut, or if we're concerned about muscle involvement affecting the gut, we may not pick it up from the biopsies themselves. Typically, if we're doing endoscopy or doing colonoscopy to try and get biopsies and look at amyloid, the site that's often performed is rectum, with the idea that it's very readily accessible, it's simple to get to, it's less invasive, and the yield from that versus other GI sites is thought to be about 75%. The highest yield of biopsies is felt to be in the upper small bowel. It's also worth noting that while amyloid can be seen with routine biopsies, it takes really a very experienced pathologist to do so. And so if you do have someone in GI who's doing endoscopy and taking biopsies and staining them for amyloid specifically, it's important to ask them to run amyloid specific stains, because if they do regular stains and biopsies only, it may not be picked up. In my practice, I once saw someone with amyloid that we eventually diagnosed, but she had 72 biopsies at outside institutions before. And going back and looking at those, most of them showed amyloid, but the issue is that the stains weren't appropriate. Now, if there's a high suspicion with amyloid, or there's thought that there's involvement outside of the most inner layer, then there are some other tests that can be done. You could look at imaging studies with a CAT scan and MRI, a barium study, with the goal of looking at gut thickness to see if there's any possible involvement there. We also have a host of different motility studies, which are mainly in specialized centers that can look at the speed with which things move down, and then also look at the muscle contraction which are present. And then sometimes we'll do breath tests to try and measure the gas production to look and see if there's a higher amount of bacteria that's present. Now, in terms of treatment, we often say the treatment should be tailored to both the symptoms as well as the area of involvement. And if we go through the gut segmentally, when looking at the esophagus, we can break that down into both problems with reflux and problems swallowing. With reflux, the first step is often dietary modification. And what we're trying to do there are to give foods that will be less likely to cause the sphincter that separates the stomach and the esophagus to open, and foods that will perhaps drain faster from the stomach so that there's less pressure that builds up. And so what we often recommend are doing small meals which are low in fat, sometimes low also in fiber, and then to try and separate from mealtime and lying down by at least a few hours. If people have set trigger foods such as chocolate or peppermint or else tomatoes or things along those lines, then we'll ask them to avoid those foods as well. But there's very little data that just avoiding those foods empirically makes a big difference unless you have symptoms with them. Once we go beyond dietary approaches, then we often look at medical therapy. And the mainstay of therapy are medications that will block or else bind acid. And so we have a couple different approaches which are there. The antacids such as Tums are very safe. They work very quickly. They're pretty cheap and readily available. They're not tremendously effective, but if people have very mild symptoms, it's a reasonable option. Histamine receptor blockers such as Pepcid and Zantac work better, and they last for about 6 hours, but they do have some resistance. So if you take them each day or several times a day, they may not work as well. And then the mainstay of our therapy are currently the proton pump inhibitors such as Nexium and such. And those drugs are much more effective. They last longer. They don't have any resistance with them, but they are much more expensive as well. For those people who still have symptoms despite those measures, we can look at doing endoscopies or doing types of operations to try and make the sphincter more tight, but that really has to be in carefully selected patients. And I'd say it's a small minority of the patients that I see that go in that direction. If there's problems swallowing, again, we often look at dietary modification, foods that are less bulky, so less meats, less often pasta and rice, with the idea that pasta and rice form these starch balls that can get stuck. And then if symptoms don't respond to just diet, then we can look with endoscopy, stretch with a balloon. Sometimes if there's spasm that's involved as well, Botox injections can help there. With the stomach, we tend to take the same approach of doing dietary modification first. Once again, oftentimes with small, low-fat meals. And then we have this category of medications called prokinetics. We have 6 of them here, which can increase stomach emptying. And so if people are getting full very quickly, if it looks like the gastric emptying is slower than what's typical, we have this category of medications which will speed things up. We also have some meds as well as complementary therapies that will help the gut expand more so that perhaps the stomach can hold more without as much discomfort. Then very, very similarly towards the last talk, we do often use medications that will desensitize the nerves with the idea that it may not improve motility, but it may make people less symptomatic. We often will look at medications such as Zofran to try and treat the symptoms themselves without affecting the motility. And in some cases, again, where we think that spasm is a big feature, Botox can help. With a small bowel, we often try and focus the diet on less concentrated sweets and less foods which are malabsorbed, so that what food is taken in can cause less bacterial issues and be quickly absorbed in the gut. We often will look at prokinetics again to try and increase motility with the idea that that clears bacteria better. There is some literature doing antibiotic trials. And then we have a few different meds that we'll occasionally use. Octreotide is one that's a nightly injectable med that can increase motility in the small bowel, which then decreases the gut bacteria load. And then we have a whole category of medications where we can use them to try and slow diarrhea. With that, the main ones are typically Imodium as well as Lamodal. But if we find that that's really not working and people are miserable because of the diarrhea, we'll occasionally use tincture of opium, which you could think of as being almost the negative GI effects with opiates distilled into a liquid without any of the euphoric approaches. So it does work very well at slowing the gut down, but once again, that's a minority of people. Then finally, with the colon, the main issue that we will tend to see there is constipation. And so again, dietary modification can help in that scenario. There are a number of laxatives which are available without a prescription. And so Miralax, Senna are typically the 2 main ones that we start with. But just in the last few years, we've seen a number of drugs which are approved to treat constipation from the FDA. And that's really changed the landscape of what we have to offer. The first 3 that I've listed here all work through the main mechanism of increasing fluid secretion within the gut, with the idea that the more fluid that you have there, the softer everything is, the more it gets propelled out. The 4th one, it was just approved in 2018, though it was approved in Europe in 2012. This works through a different mechanism of increasing contractions within the gut. So we sometimes will use one from the first 3 plus the 4th one in combination. And there might be some synergistic benefits with that. And then finally, prokinetics again can help here. Now, if we step back and we look at how often we find amyloid with the gut and what we know about gut involvement with variants specifically, there's some interesting literature that does emerge. The first to me is that gastrointestinal involvement with amyloid, where it's biopsy proven, is surprisingly low. And so in 2013, there was one study that looked at over 2,000 patients, and only 3% of them were found to have amyloid with GI biopsies. Now, to be fair, not all of them underwent endoscopy, and so if everyone was getting endoscopy, the yield may have been higher. But this was still lower than I would have thought. 2015, there was a study from Korea where they found that only 15% of patients had actual deposition with biopsy. And then at Stanford recently, we had looked back at our series, and we found that 16% of patients with amyloid had gastrointestinal symptoms, and 6% total had signs of biopsy deposition. So now this might reflect the fact that amyloid deposition may be occurring in different areas in the muscle and nerves, and we aren't picking it up from the mucosal biopsies. If we look at variants, the data is limited, but the data from Theos would suggest that in people who have hereditary variants, specifically neuropathic variants, that the presence of gastrointestinal symptoms is more common and probably seen in about 60% of people. But interestingly, in wild type, it was only about 15% in their series. The most common symptoms reported were unintentional weight loss, as well as early satiety, meaning getting full very quickly from meals, and then alternating diarrhea and constipation. GI symptoms were more common with third DM versus other ones, but if you step back, more common within neuropathic variants, and were also more common in those patients who had symptom onset below the age of 50. And the authors concluded that for patients with predominantly cardiac complications and wild type, that in their words, the prevalence of gastrointestinal was not evidently higher than expected in the population. Now, if you look at that, we do see 20% of American adults will have symptoms of reflux once a week. We see constipation in 15% of adults. We see symptoms of irritable bowel in about 13%. So the fact that only 15% of the wild type in their series had gastrointestinal symptoms, could fit with that data. This is what they had reported with time, and it did appear that the longer that someone was diagnosed with amyloid or had symptoms attributed towards amyloid, the more gastrointestinal symptoms they had, but that line was not relatively sharp. And when they stepped back and looked at different variants as well as different symptoms, you can see that if there's any neuropathic component, at that point the gastrointestinal involvement tends to be higher. If it's primarily cardiac, the gastrointestinal is lower. And for those who have wild type, again, only about 15% had gastrointestinal symptoms. And of those, the most common tended to be early satiety and then constipation and diarrhea. So to conclude, we can see gastrointestinal symptoms with amyloid by either direct deposition or by nerve involvement. Only the inner lining, referred to as mucosa, can be evaluated with endoscopy because the biopsies don't get to deeper layers than that. And proper staining is typically recommended to make the diagnosis of that. Involvement appears to be common in variants which are neuropathic, but it's unclear if it's higher than the general population in wild type and cardiac variants. And we do have a large number of diagnostic options as well as treatments which are available, which we can customize towards those specific symptoms which are present. Thanks very much, appreciate it, and I look forward towards questions afterwards.
Thank you so much, Dr. Clarke. Really appreciate that. And you've got some questions already, and we've got a lot of written questions for the Q&A as well.